if you were to ask my family, I have a number of unusual obsessions. So one of the things that I work on now is I have a 1975 F-250 that my brother helped me purchase a few years ago. He's a huge truck collector. And 73 to 79 Fords are kind of the dense side Ford pickups are kind of the focus of his collection. And so I have a 75 version V8, and it came with a pretty crappy paint job and with a ripped up interior. And so this summer, for example, I replaced the dash pad. We replaced the door panels on the inside. My dad and I replaced the moldings along the door. I just had the windshield gasket replaced, found a guy to repaint it, and just had the interior reupholstered. So that's kind of been my summer project. Whenever the home is a little bit chaotic, I sneak to the to the driveway to work on the truck.
I am Czubernat, an injury attorney in Chicago, and this is the Czubernat podcast. You can learn more about my work at czubernatlaw.com. My guest today is Dr. Mark Sokolowski, an orthopedic spine surgeon. Let's go off the record. I find it quite often that people who work in an office setting, for example, like other lawyers, a good number of them got hobbies, like even myself, that require manual labor.
Yeah, I think it's a good way to, A, do something that's different than what you do during the day, and B, it's a good way to like get a little bit of physical exertion, kind of tire yourself out at the end of the day. And then the kids know that they can find me on the driveway working on the truck if they need anything. Generally, they don't want dad around too much, keep telling them get off technology.
Being a surgeon, are you concerned about your fingers getting caught somewhere or cutting your hand somewhere?
No, not generally. I usually have a number of cuts and bruises and things like that. No, I wouldn't say I'm overly cautious. I don't really give that much thought, I would say.
Do you use table saw?
My dad has a table saw. I use his table saw. My dad has a pretty good collection of tools. He lives not far away from me. And I do a fair number of things that later I say, like, gosh, maybe I should have used safety glasses, or maybe I should have been a little bit more cautious.
I don't know any surgeon who's a woodworker, and I also thought for a good reason. They don't want to jeopardize their livelihood by messing with the table saw.
It's possible that people think about that, but I would say most of the surgeons I know, nobody really. I think probably in popular culture, people say like, gosh, your hand is your livelihood and things like that. Yes, I have disability insurance, but I don't know that I give a lot of thought to protecting my fingers or anything along those lines. Protecting my head, maybe. As I get older, when I get on a ladder now, I think a little bit more like, gosh, you fall enough I'm at a sufficient height where I could fall and get a brain bleed, and that would be suboptimal.
What's one of the very first patient stories that stuck with you?
There have been a number of patients throughout the years that kind of have changed a little bit of my approach or have kind of changed my worldview a little bit. Probably one of the earliest experiences in terms of patients was I did my residency at Northwestern. I grew up in the suburbs. I did my residency at Northwestern, and Northwestern's a level 1 trauma center. But the trauma there is a little bit different than the trauma, for example, at Cook County Hospital. And so part of our residency rotation was that we did a hand surgery rotation at Cook County Hospital, and we did trauma rotation at Cook County. And any orthopedic surgeon who practices in an urban area will have some exposure to gunfire, but gunshots were relatively rare in terms of the mechanism of injury at Northwestern. And I remember that in my hand surgery rotation, my first night on call at Cook County, and this won't be a surprise to anybody who takes call at Cook County Hospital or a similar urban area. I remember the first night on hand surgery call, there was a gentleman whose fingers were largely blown off by someone who had shot at him. And he had taken some measure to protect himself reflexively, and he had a number of mangled fingers that came in. And I remember it was probably the most dramatic hand injury I had seen, even though I was in my second or third year of residency at this point. And I remember calling the hand surgery attending on call, and the hand surgery attending said, look, you've got mangled fingers. You have to just address the problem, save what you can in the emergency room, and we'll deal with the rest later. And I remember that one thing about the Cook County Hospital emergency room, it's a very busy emergency room. There's a number of calls for patients with hand infections, et cetera. And we just ronged off the nubs of the fingers that were clearly not salvageable at that time. bandaged him up and saved what we could. And we admitted him for intravenous antibiotics and dealt with him the next day. But I just remember that this was kind of a wake-up call, like, holy cannoli, there's like a lot of trauma from gunshot wounds that even though you might be an orthopedic surgery resident, I might be at a level 1 trauma center, and I see a lot of blunt trauma, car accidents, things like that. Really, the one thing that the time at Cook County Hospital woke me up to was A, the number of gunshot injuries, and then B, the number of people who presented in a delayed fashion for care. So while up until that point, I had seen patients with fresh fractures, and we would operate on fresh fractures and restore normal anatomy. On that hand surgery service, instead of doing like a lot of fresh wrist fractures, we did a lot of osteotomies, correcting fractures that had healed in a poorly united fashion because those patients didn't have access to care initially, or they neglected their fracture. And by the time they got seen by the orthopedic surgery service, they had already healed in a suboptimal position. And then they had a corrective osteotomy to restore normal anatomy. So in terms of early experience that kind of changed my view of the world, it was like, wow, that like, Toto, we're not in Kansas anymore. Like the real world has some pretty wild trauma, and the real world has some pretty difficult problems in terms of access to care. And those were good experiences at County during my residency. And then when I went into practice years later, my primary hospital for taking call was West Suburban Hospital, which is on the border of Oak Park and the Austin neighborhood. And really, I gotta say that the exposure to trauma at County really prepared me well for the exposure that I would have taking call at West Suburban and at Elmhurst and at other area level 2 trauma centers, things like that. It really kind of woke me up, and that was kind of pivotal in my own early experience in terms of teaching me what else is out there in the world beyond our narrow view of what trauma is.
What's the difference between treating a trauma patient who just got shot at as opposed to somebody who had an accident at work or was injured in a traffic incident?
I'd say there's a couple of different considerations. So patients who had, let's say, a car accident might be a blunt traumatic mechanism. So you've got maybe a relatively clean fracture line. Let's say there's a twisting injury or an ankle fracture. It might be a relatively clean fracture line without a lot of comminution. Comminution means like a lot of bony fragmentation. In addition, blunt trauma might have a soft tissue injury pattern such that you might have a fair amount of soft tissue trauma. Let's say you have a twisting injury. Gunshot wounds are divided into low velocity gunshot wound and high velocity gunshot wounds. The cutoff is 600 meters per second. I don't know why I remember that, but it is. And a bullet that leaves a handgun travels at less than 600 meters a second is considered a low velocity injury. It's a high velocity injury, obviously, but it's a low velocity injury, and something that leaves a shotgun or a rifle is over 600 meters per second and is a high velocity. And the primary distinction is the amount of kinetic energy that bullet carries determines the amount of soft tissue trauma. There is trauma that's directly from the bullet. So a bullet injury will cause comminution, will shatter the bone into a lot of pieces. It will cause a cavity behind the bullet, and it'll cause a contusive injury in the limb. So depending upon where the injury is, the nature of the injury, and the other thing that like a handgun injury is that you might have a small skin entry point and a small skin exit point, but there might be a hidden vascular injury that is not apparent, but just based on knowledge of anatomy, you might say, gosh, injury in this limb at this level, this artery is at risk, and you might do a vascular surgery workup, or you might, at the time of surgery, you might do fasciotomies, kind of cut the fascia to give the muscle room to expand, et cetera.
So how do you think that experience treating that patient who got shot at and got his fingers blown off, how do you think that changed your approach to, I guess, trauma and the injuries that patients present with?
A couple of ways. One is it taught me early on that like my suburban view of trauma is not necessarily a representative of a worldview of trauma. There's a lot of traumatic injuries out there that are far more significant than we might just sit here. A lot of orthopedics might be, especially today, I have an elective practice. There's not a lot of trauma, acute trauma. I don't take trauma call, for example, anymore. But it opened my eyes to the fact that there's a lot of trauma that I don't necessarily have an appreciation for until that point when I said, like, wow, there's a lot of different varied injuries. And the second thing is that just in general, that whole experience taught me that a lot of times folks might have difficult access to care. And so one of the things that's carried through with me is that if I'll see someone in the office, let's say they have an injury that's, let's say, disputed or something, that someone's injured at work and the insurer is disputing the causation or something, some factor that I can't control. But I know that that patient needs therapy, or I know that that patient maybe needs an injection, or I know that that patient needs medication as the measures that are most likely to restore their function most quickly. I might, because I have the benefit of having, let's say, my own therapy center, I can just start the therapy and figure out the remuneration aspects later. Or I can just get them an injection if they need an injection. Or I can take measures to start treating that patient who might have otherwise access to care difficulties, help overcome that initial barrier, and just get the process moving so that we can restore their function, get them back to a productive member of society, et cetera.
Just before I hit record button, you had a chance to play with one of my dogs a little. When a dog, especially like a big dog, bites you, these are not clear-cut wounds. These are deep puncture wounds that require a lot of more treatment than what meets the eye, as you said with the gunshot wound.
That's true. And that's actually especially true for like human fight bite injuries. Often someone will punch somebody else and they'll sustain a little fracture to their metacarpal, maybe a little gouge in the bone. And there'll be a soft tissue injury, which is relatively underwhelming. And folks will put a little Neosporin on it or bacitracin, or folks will have a dog injury, or even more so a cat injury, a cat bite, because the depth of the puncture is generally a little bit greater. So the skin injury will underestimate the relative severity of the potential for infection. And then within 48 hours, it's like a florid infection. So in those cases, dog bite, human fight bite, cat bite, it's important to go seek care. Sometimes it's necessary to expand the wound a little bit in the emergency room, really thoroughly lavage, wash out that wound, and start prophylactic antibiotic care. And then generally for bite injuries, they're often not closed primarily. You don't want to close them up because you're, just trapping in the bad things and not allowing the bad things to escape as this wound kind of granulates in from the bottom up.
That's one of the things I was surprised to learn. I'm no doctor, but dealing with dog bite cases, people would say, no, they didn't stitch me up. I don't have any stitches. And I always found that puzzling, right? Mm-hmm. You got some deep puncture wounds and nobody stitched you up. No, they left it like that. But I guess that is the course of treatment.
A lot of times a wound will nicely heal like a little volcano. It kind of granulates in from the bottom up. And then ultimately the skin will close over and remodel, et cetera. But you're right. We want to let the bad vibes out and aggressively clean that wound in order to prevent complications. Because if you don't, within 48 hours, you've already got kind of a mess. And once you start to get a deep infection in the hand, it's difficult to treat because you have a relatively poorly vascularized area. Now, I'm not a hand surgeon. That's my caveat. I haven't done a hand surgery in a long time. But you have a relatively poorly vascularized area that you need to get antibiotics to. Your bloodstream carries the antibiotics to. You've got relatively tight spaces. The flexor tendons are in a relatively confined space. So you've got the potential for accumulation of pus and bacteria in a tight space, and you can have some pretty devastating clinical consequences without aggressive treatment.
One advice that I tell my friends and other dog owners is to always have the dog's vaccination record on your phone, not somewhere in the shoebox under your bed. Have it on your phone, right? Have a picture or put it in some cloud storage. But when and if your dog bites somebody and the police shows up, the first thing you want to do is pull up the vaccination record so everybody knows what they're dealing with.
Well, that's really smart. I have a dog and I've never thought of that. So that's actually very smart.
As a lawyer, I often get phone calls from people who were injured in various kinds of accidents, car crashes, workplace injuries, you name it. And very often they think they can walk it off, right? As you said, let's just slap some Neosporin on it and it will go away. It will be better tomorrow. Or maybe I will take few ibuprofens and feel better tomorrow. And my advice always is seek medical care as soon as you can, as soon as possible. There really is no downside to getting fast medical care. But I'm curious if you can recall a specific situation, specific patient where delaying treatment really screwed up the prognosis and the chances of recovery for that particular patient.
Well, I can tell a story about a specific patient named Mark Sokolowski. I don't know about the importance of medical evaluation and advocacy for yourself. We have this nice clinic building, and there's 16-foot ceilings in the building. And there are times when males, females as well, will have the urge to do some remodeling and renovation. And I satisfy that urge by making some subtle changes, et cetera, to the clinic as time allows. And there are some things that I'll say like, gosh, it would really be nice. For example, we've done a little bit of renovation. That wall would be nice to paint. I'll come in on Saturday and paint that wall. But for whatever reason, the 4:30 p.m. patient on a Friday cancels and physical therapy is still going. And I'll say, well, I'm not supposed to be home till after 5 anyway. I'm just going to go ahead and paint that wall right now. And so on one such Friday, my physical therapy was still going in my clinic. It's in the way when you walk into my clinic, there's the main lobby, little foyer, and then we have a big therapy space, and then we've got the front desk, et cetera. And I was painting the front wall, a nice, lovely shade of brown to contrast with the Revere pewter that was elsewhere. Very, very modern. And I had set up the ladder, and I'm 9 feet off. My feet are 9 feet off the ground to paint the top of the 16-foot wall. And patient walked in, and I said, "Oh, hi." Let's just say it's Mr. Smith. "Hi, Mr. Smith. Just be careful. My paint tray is over there." And as I turned to say that to him, the ladder twisted on the drop cloth a little bit, and it's an A-frame ladder, 12 foot tall, and it fell onto its side. And I fell ribs first. My ribs were probably 12 feet off the ground, 13 feet off the ground, rib side first. And I, in front of all my patients in therapy, just ate it on that ladder right there. And there was no way to play it cool. My therapy patients came over and like, what the hell just happened? And I couldn't catch my breath. And first thing I did is I said, holy crap, I've got a pneumothorax and a liver laceration. I'm going to die here because the pain was intense and I couldn't catch my breath. So then I said, okay, I'm breathing, but I'm like horribly shaken. I have this insane pain. And I told my staff, I'm driving home. And they're like, dude, you cannot drive home. Call the ambulance. I said, I'm not driving. I have a high-deductible health plan. I'm not calling an ambulance. So on the way home, I called my wife and I said, I'm going to get home. I just had this horrible injury from a fall.
Are you one of those people that refuse ambulance?
Yes. I got a high-deductible health plan, man. So I'm driving home and I called my wife. I said, I'm coming home, but there's a chance you might need to take me to the ER. So we get home and I barely make it out of the car and I'm like breathing heavily. And I said, that's it. We got to go to the ER. So we go to the ER and I tell the ER doctor, I said, hey, can I get a CT of my chest and a CT of my abdomen? And he says, well, we can do one or the other. We can't do both. And I said, no, I really need both. I need to make sure, A, I don't have internal hemorrhage and liver laceration, et cetera. And B, I need a CT of my chest to make sure I don't have a lung fracture, pneumothorax, lung contusion. And anyway, they ultimately order one chest x-ray and CT of my abdomen. And they say, good news, you don't have any abdominal bleeding. I was developing this massive flank contusion here. And I said, it's going to be a painful couple of days. And I was thinking also, A, how am I going to continue working? B, did I sustain some head trauma? Am I going to be able to support my family, et cetera? All the stuff that normal people think about when they have an accident. Anyway, 48 hours later, I woke up in excruciating pain. I couldn't get out of bed. Every bump on the road to work was increasingly more painful to the point where I would come into the room and I would sit down with the patient on the stool and I would be wincing and trying to hide my pain. And I would say, let me help you, tell me your story. And I would listen to them do their diagnostics. But the pain was progressively worsening. So I called the local CT place, got a CT of my chest over lunch. And sure enough, I had extensive rib fracturing that was missed during the ER visit? During the ER visit on the chest x-ray. So ultimately then, multiple rib fractures, I'll heal conservatively, et cetera. But I had an explanation for my pain and I had an accurate diagnosis as to what my injury was. And so sometimes, doctors are criticized for getting too much imaging in the short term after an injury. And they say, gosh, why are you getting imaging? Well, if I told you the number of patients that had significant chest pain with chest radiographs that initially missed their rib fractures that were ultimately elucidated on CT, or a sternal fracture that was initially missed and elucidated on CT, or a lung contusion, or even a small hemothorax, there have been many, many patients in my practice. And I also am one such patient. And I can tell you that it is when you have unexplained pain that is increasing over 48 hours, you really become concerned that something, dramatic is going on. And I can tell you that in just knowing the diagnosis, okay, you've got multiple rib fractures. Now you know prognosis is going to heal over the next 12 weeks. You're going to wear this this strap. There's some controversy about wearing a strap, but obviously I'm a doctor. I can't take narcotic pain medications to do my job, so I wore a strap. I took anti-inflammatories. I did lidocaine patches, all non-narcotic measures, so that nothing affects my cognition, etc. And there is some comfort in having a diagnosis, because if you don't have that diagnosis, you start to say, what's going on? I'm going bananas over here. My function is markedly decreased. I can't do routine activities of daily living. And so if anything, that experience has taught me, look, there is an advantage to seeking medical care early, but seeking medical care early alone is insufficient. You have to advocate for yourself. You have to say, these are the parts of my body that are injured, because on day one, your day one assessment of yourself may not accurately reflect your symptoms at 48 hours, 72 hours, 96 hours after. And then it's a weekend, and then good luck finding someone to see you and give you care on the weekend. It's taught me aggressively seek care. It's okay to err on the side of additional imaging, because often erring on the side of additional imaging increases your diagnostic specificity, can dictate your care. And so I think, yes, if you are injured, seek care. I can say that with an exclamation point, myself having been through that experience. If you are injured, even if you don't want to call the ambulance, even if you don't initially want to go to the emergency room, even if you have a high-deductible health plan, seek care.
Very good point. And I guess the moral of the story is sometimes it's helpful to get the second opinion, like you did with the imaging place.
That's right.
And also to that, I think people underestimate what adrenaline does to a human body. I know of people who were badly injured and they didn't feel it. That's how I learned how much a lot of adrenaline in your bloodstream can really affect your perception of your own injuries, of your pain. You may have fractures and not even know about it until you look down at your foot.
100% agree. That in that acute post-injury moment, there's some mixture of shock, embarrassment, adrenaline, and a desire that, being naturally optimistic people, we're like, oh, I'm going to walk it off. It can't be anything bad. But sometimes it is something bad. And sometimes medical intervention, timely medical intervention, is appropriate, justified, and necessary.
And also, as a personal injury attorney, what I tell people is, listen, calling the ambulance and getting wheeled out in an ambulance, it's not only giving you the necessary medical treatment you may require, but the ambulance arrival also confirms where the accident happened. If you slip and fall in a parking lot and then drive yourself, you're still in a shock, badly injured, but you drive yourself to the nearest hospital, good luck proving where the accident happened, right? So the ambulance is dispatched to an address which gives your case even more legitimacy.
Yeah, that makes sense. Something I've never thought about or considered, but yeah, absolutely. That seems like a good tip.
We just discussed imaging and how sometimes the doctors may order too few as opposed to too many. But I'm curious, what else do doctors, surgeons like yourself, what else do you look for to pinpoint that injury and have the proper diagnosis for the patient?
Yeah, I'd say that probably what's the benefit of being seen by a doctor post-injury, or an orthopedic surgeon, or a spine surgeon, or whatever? Why be seen by somebody? Because, imaging is certainly an objective modality, right? If you have a disc herniation in MRI, nobody can say that you don't have a disc herniation in MRI. Or you have a fracture on CT, nobody can say you don't have a CT. But the physical examination is very objective in the hands of a person who's trained to do a good physical examination or someone with a lot of experience, right? Because your doctor can notice subtle things neurologically that you may not notice. So for example, a patient might come in after an injury and say, gosh, I've got neck pain. I've got pain along the inside border of my shoulder blade, and I've got this numbness and tingling in my thumb and index finger. And I might say like, wow, that sounds a lot like C6 radiculopathy, right? And periscapular pain could be the dorsal ramus of the nerve root. The thumb and the index finger could be the C6 nerve root. And we might do a physical examination, and it may show a decrease in the muscle group that corresponds to C6. And we could say, put together, wow, that's an objective documented finding. Or for example, someone has a more serious injury. One common thing that I'll see in treatment of laborers is that people will fall from like a roof height, because a lot of guys are roofers and they're not secured to the roof, because putting on the safety harness, it takes a long time and it might be uncomfortable on a hot day, et cetera, or it may not be important to that employer or whatever. And people fall from a roof height. Well, roof height is enough to get like a spinal cord contusion. And you might have a spinal cord contusion, which will ultimately be manifested on an MRI as, let's say, some increased T2 weighted signal or whatever. And there may only be a subtle neurologic finding. You might have a small change in a reflex. You might have a subtle Hoffman sign, which is a little upper motor neuron reflex. Or you might have a few relative hyperreflexia in your legs, or gait instability, or maybe a little bit of posterior drift on Romberg's testing or whatever. You might have a subtle neurologic finding that a trained examiner can pick up that you might just disregard. And that's why there is so much objectivity in that initial physical examination. A lot of times people will say, oh, the only objective measure is an imaging study. Well, a good physical examination is certainly objective. If you look at a patient that's got our patient may have, for example, an injury, a significant soft tissue injury, and you might say, holy cannoli, look at all that bruising. There's like some sort of soft tissue degloving injury in there, that you could say like, wow, the injury signs that you might just chalk up to bruising might be indicative of a much more significant soft tissue injury that you're underestimating yourself.
Have you ever had a situation where imaging looked good, but thanks to a thorough exam, you were able to uncover the underlying issue?
Yes. So a couple of examples that just come to mind. One is moving away like from an injured patient, for example. Sometimes patients will come in and they'll say, gosh, I have gait instability, that I feel like I'm tripping over, or I feel like my legs don't work right. And until in the treatment up until that point, they've gotten, let's say, x-rays of their low back, x-rays, some sort of workup of their legs. They've checked the blood flow to their legs. It's been fine. And they've gotten an MRI of their low back, because, most physicians know that the low back will cause some lower extremity symptoms, and the MRI of the low back is clean. But they'll come into the office and we'll just ask, what are things that you have difficulty with? And they'll say, I feel like my feet give out on me, or my walking has changed. And then we'll say like, well, what else have you noticed? And they'll say, gosh, I have trouble with buttons, or my handwriting has changed. Or I'll notice that I'm losing a little bit of fine motor skills. But that's not the presenting problem. The presenting problem was gait instability. My legs are tired. I can't walk as well. I can't keep up with my friends. And then those are clues to your orthopedic surgeon, or your neurosurgeon, or your spine surgeon, or even your family practice doctor, internist, that, gosh, there might be something more proximal going on in your spine. So yes, most of the time, lower extremity effects are from the lumbar spine. That's the lower motor neuron. But sometimes you can have myelopathy, which is severe spinal cord compression of the actual cord of sufficient severity that it causes upper motor neuron findings, that the signal from your brain to your legs is interrupted not by the nerve root from your low back to your legs, but by the nerve from your brain to your spinal cord, the upper motor neuron. And in those cases, we say, okay, you've got some interesting findings on exam. If you close your eyes and hold your arms out, you fall backwards. You're relatively hyperreflexic in your arms and your legs. You've got some strange sensory findings on pinprick and light touch examination. And then we'd get an MRI of the cervical and the thoracic spines to look above the spinal cord termination. And we might find a big lesion in the neck that only presents as a lower extremity pathology, is what the patient, only thing the patient notices.
There's this perception that the MRI will tell a patient everything. And I don't want to say they are being dismissive of a proper evaluation, but it's somehow secondary to a good quality MRI that supposedly will show them everything.
Yeah, I think so. The MRI is a great test. MRI is a great test, and it significantly enhances our ability to diagnose things objectively and radiographically. And it's obviously an important part in the armamentarium of a workup of a patient. But are there things that an MRI is not great for? So one thing that comes to mind is an MRI may not always give you precise bony detail like a CT would, for example. So some patients have a bias against the CT. They'll say, gosh, so there are some situations which the CT is the lousier alternative to the MRI, and there are some situations which the MRI is the lousier alternative to the CT. And in the emergency room setting, a CT is much more rapid. You're probably going to get a CT if you get anything beyond a planed X-ray. You're probably not going to get an MRI. But you say, like, where's a situation where an MRI may be inferior to a CT? And that's when you have precise bony detail, for example. So along the lumbar spine, and this is something I just saw within the past week, along the lumbar spine, at every level, you've got if you reach around the back, you've got the spinous processes, and then off the next little bump that you feel to the sides are the little facet joints. And then deep in there are these transverse processes, these little lateral bony extensions. The MRI captures some sagittal images. So sagittal are if we cut you down the side and we look at you. And they usually go from the left side of the spine to the right side of the spine. But sometimes those transverse processes are outside of those sagittal cuts. And so I had a patient, for example, that had an injury, fall, significant pain throughout the lumbar spine. X-rays, unremarkable, because it's hard to visualize the transverse processes. They're deep to musculature. They're relatively small. People are looking on the X-ray often for like a vertebral body fracture, something big and obvious. And then unexplained pain, they get an MRI. Well, it turns out that the transverse processes were just outside the sagittal cuts. The window that captured the spinal canal from left to right was this big. In order to see those transverse processes, you needed to go this big. And so, on the cross-sectional cuts, the cuts just missed the transverse processes. And then they get a CT. We're like, well, let's take another look. There's something quite not right here. And they get a CT, and the CT gives you bony detail that is otherwise missing on the MRI. And you can pick up a fracture of a transverse process better than you could on an MRI. Now, conversely, you can have patients who have an X-ray, and they can have a CT for, let's say, a vertebral body compression fracture without collapse, but there's an occult fracture, and that may not be visible. Or they might have a fall and an X-ray of their hip might not show a fracture. But you get an MRI, and because an MRI will show you edema, T2 weighted signal or a stir signal will show you edema within the bone, you can say, holy cow, there's an occult fracture that the CT or the X-ray missed. So there's no perfect objective test. Sometimes you need a healthy degree of suspicion, a physical exam, a good history, and 1 or 2 or 3 objective tests to explain the pain. And even though things should be obvious, we say, gosh, we got the gold standard MRI test. If it's not there, it can't be anywhere. Or we got the CT. If there's nothing there, you don't have anything. Sometimes having a healthy dose of suspicion and the patient reporting insufficient response to treatment based at the identified pathologies, you look a little further and you can pick something up.
This is fascinating, and I can relate when I have patients coming to my law office and they present, like you said, patients to your clinic, and they think they came in with one problem, right? And they're asking me counsel, how do I take care of this? But when you ask the right questions and you look at the the whole picture, you realize, well, the problem that you came with is really a symptom of a bigger problem.
One general rule that I think is good is that if the patient is not responding in the expected fashion to the measures that are treating the pathology you've identified, sometimes you have to look a little bit further. And sometimes when you look a little further, you'll find something that explains the pain that you missed altogether.
From your perspective, what's the biggest misconception that people have about their bodies, especially with respect to traumatic injuries? Is it always that less pain equals smaller injury, more pain equals bigger injury, or is it more nuanced?
I'd say the biggest misconception, look, humans are generally optimistic, right? So we slam our fingers in the door, we stub our toe, we get into an accident, we fall off a ladder, and our natural inclination is to say, I'm going to walk this off, I'm going to be okay, right? We're a generally optimistic people because most of the time we're right. We're going to survive this, whatever just happened. But I would say that the biggest misconception is that the absence of life-threatening injury somehow means that we're not injured is the conclusion that we draw. And thankfully, most of the injuries that we sustain are not life-threatening. That's why most of us live into our 70s. However, we have a tendency as a human population to underestimate the things that the injuries we have. And that's the same reason why people will have subtle signs of being ill, but we tend to write them off, right? You'll say like, gosh, I have this cough that won't go away, or I have this mole on my leg that looks unusual, but I'm sure it's okay. Or I have whatever. And that probably is evolutionarily protective in some respect, in that we go out and we go to the next cave and kill the next bit of food and we don't sit and wallow in our misery. But at the same time, it's probably somewhat evolutionarily disadvantageous because we have a tendency with our relative optimism to disregard otherwise obvious clinical signs that may be apparent to someone else. Like if you were to say, gosh, I've got this mole on my leg and it's been looking more and more scary every year, but I think it's going to be okay. And then your loved one is like, holy crap, it's probably not going to be okay. So go get that checked out. And so sometimes you need another person who is removed from your situation, is not as emotionally invested as you are, right? Someone who's an impartial person to say like, you should probably go get that checked out.
So what do you think about this popular saying that what doesn't kill you make you stronger?
Probably true in the gym. As you can tell, I'm not a frequent gym attendee. but this big Polish muscle over here. But probably true in the gym, but may not be true in all other aspects of life. There's something scary about going to the doctor, which you might say, gosh, Mark, that's crazy to say. You're a doctor. How is that crazy? But there's something, initial reluctance to go to the doctor. And then there's something scary about going to a surgeon, right? Because you think that the visit is going to end in surgery. I, too, am reluctant to go see my doctor. My doctor is a nice guy, but I'm 49 years old. And when I go to that visit and he starts to put on the one blue glove, I say like, maybe I shouldn't be here. I shouldn't stay for the rest of this visit. I should have rescheduled. I should have told them I'm sick today. So I too am reluctant to go to the doctor, and what you need, and there were years, like probably 3 years, where I didn't go get my annual physical, even though it's covered by insurance, 100% high-deductible health plan or not, your physical is covered. But I didn't go, and then you don't go until your family's like, dude, we'd like you to be here a little bit longer. You should probably go get checked, and you should probably go do routine lab work. And then I say, but what if it affects my future insurability for life insurance or disability insurance? What if there's something wrong? Do I want to know if there's something wrong? Yeah, you kind of want to know because there's people who depend upon you.
So we've been talking about injuries and traumas for a while, but have you ever met a patient or have you ever dealt with anyone who had like a really unique coping mechanism with their injury?
Majority of people cope with their injuries by saying, I'm going to, my stated goal is a recovery of function, return to my usual life, and there are some necessary changes I make along the way. There are some patients who have suboptimal coping mechanisms, right? And those might be folks who become depressed as a result of their functional limitations. And that may be a natural consequence of it. I see a fair amount of depression and related issues in my young, injured male workers. And you say, like, how does that make sense? Well, you have a guy who goes to work 7:30 to 3:30 every day with a physically demanding job, comes home and is physically tired, sleeps well, because the next day he's got to get up at 5 to get to the job site, work 7:30 to 3:30, and in the course of that day, expending a lot of calories, working really hard, physically demanding job. Now you have this guy injured at work. Let's say it's an ankle injury or a back injury, and you're unable to work. Your job doesn't take, for example, let's say there's no light duty work available. So you're a laborer, you need to have a 100-pound lift to go back to work, which is a very common situation. Folks who are classified by the Department of Labor as very heavy have a 100-pound lifting threshold, and many jobs don't offer light duty. So you've got this, let's say, 25-year-old guy, since 18, working hard every day, exhausted, now is sitting at home, coming to therapy 3 times a week. But what happens when you're at home? Well, you're not working. Your wife sees that you're not working. Source of stress, right? Why are you just sitting on the couch all day? Honey, it hurts. I can't do it. Get off your butt, do something, right? So there's marital stress. 2, you were physically tired after work every day, but now your body is used to this physical fatigue, but you're not getting physically tired during the course of the day. So you don't sleep. Interrupted sleep leads to, contributes to the pain cycle, and all of this leads to depression. So years ago, I met this psychologist. Actually, a lot of my patients speak Polish, and there's a psychologist, this guy, Dr. Thomas Rostofinski, gentleman who's at Loyola, and he's a psychologist, not a psychiatrist, so he's not pushing medications. And this is going to be an inadvertent plug for Rostofinski here. And I don't have any financial incentive to refer to Rostofinski, and I don't hang out with him socially or anything. But my patients do very well. And I believe he does like a biofeedback mechanism where you have pain. It causes like heart rate acceleration, blood pressure elevation. And he does all this like natural coping mechanisms for pain. And he does a really good job in folks who have post-collision avoidance of driving. They have anxiety after a collision. I got hit with this truck in a T-bone fashion. It freaks me out. Now I'm driving, and every time I look over my shoulder and say, like, holy crap, this truck is going to hit me. And so I refer, if you said, how does my practice different today than it was when I started in 2007, 18 years ago? That I'm, I guess, a little bit more in tune with the social aspects and the coping mechanisms of injury than I ever was before. And early on in my practice, I was like, I can fix anything. I need the MRI. I can always make an X-ray look better, etc. Later on in practice, you're like, well, these are the other barriers. I think just some of it is having lived experience. These are the other barriers to care. And I might say, hey, you should see this guy, Rostofinski. He might give you some positive coping mechanisms that help you overcome these psychological barriers and help you just focus on your recovery.
That's fascinating, because now that you reminded me, years ago, I went to this family law event, and one of the speakers, one of the divorce attorneys, that was the main speaker, said that she would not take you as a client in a divorce case unless and until you have a letter from a psychologist that you are under an active care of somebody. And her explanation was that this process is so emotionally draining, right, and challenging, that if you don't have somebody dedicated, some professional to help you with it, you will try to turn your attorney into a support person, and that's really not it. Your attorney is to fight the legal battle, not to really, have deeper conversations with you about your emotional status and how you feel. So that is interesting that you're doing this in your practice, because I've heard about it years ago and I thought, well, I wish I were at that point in my practice where I could be so selective or so demanding, right, of whom I take as a client.
Yeah, there are even some surgeries and part of the approval threshold. So for example, patients who've undergone lumbar laminectomy and have incomplete relief of leg pain, and they have kind of this failed back surgery syndrome. And their pain doctor might propose a spinal cord stimulator, which basically the idea being that it interrupts some of the signal pathways of pain from your lower extremities to your brain. And one of the criteria for approval of a spinal cord stimulator, it varies insurer to insurer, is clearance by a psychologist that the patient is likely to benefit from. The patient doesn't have any psychological contraindications to this procedure, is basically it. And so there are times in a spine surgical practice, more often than I would have predicted, that we refer to psychology. And it's interesting. So it's still a small fraction of our patients, but it's still interesting. And I became even more aware of it. My sister, my older sister, like myself, started her career as an engineer and later in life went to med school. And she's now a psychiatrist and palliative care doctor at Mayo. And she has kind of even opened my eyes beyond what I had kind of learned on my own as to like the aspects of suffering and pain that are psychological and the adverse effect it has upon your life holistically, beyond what the narrow focus that one might see in just an orthopedic or a spine surgical perspective.
One thing that we didn't mention and also comes up as a significant pain point, not literally, is the financial strain. As you mentioned, that poor gentleman that's not working, not providing for the family, sitting on a couch because he's unable to do anything else. On top of all of that, and that pain, there's no income or very little income, depending on the type of the case he has. That financial strain alone stresses healthy people and leads to sleepless nights, let alone somebody who's in constant pain and yet has that financial burden to carry.
Yeah, I 100% agree. I honestly can say when I fell off that ladder, in addition to the physical pain, through my brain flashed, do I have enough disability insurance? What if I'm unable to work? What's my exclusion period? Like you start to think, am I relatively underinsured? Like you have all this crazy stuff because you have mouths to feed at home and you have employees that are relying upon you for salaries at work. And you say like, wow, have I thought about like the continuity of my practice and the continuity of my family in the event of an injury? And I can tell you that after that fall from a ladder, I went back and looked and it said, what this is not like a primer for insurance here, but to say like, am I adequately insured? And you say like, okay, but when did I buy disability insurance? Well, I bought it in 2007. Is my financial situation in 2025 reflective of my financial situation in 2007? And then you say like, well, do I have business interruption insurance? Have I been setting aside money in an HSA in case I need to use that high deductible health plan? Like all these thoughts kind of like when you're sitting in the ER waiting for care, you're like, holy crap, I got to go to work tomorrow because if I don't go to work tomorrow, the employees don't have a job tomorrow, family doesn't have food tomorrow, or I have a 90-day exclusion period, all these things. And that are the same considerations that I'm sure my patients have following an injury.
In my early podcast episodes, I discussed insurance coverage at length. And one of the things is that the time to review your policy is not the day of or after the accident, right? You need to know earlier what you've got and how you can make it better. Reviewing your policy after the car crash or after the fall off the roof, no, that's a foregone conclusion.
True.
It's a little bit too late for that.
That's true. But sometimes you need that wake-up call to say like, okay, so hopefully you recover from your acute trauma. I didn't end up missing any work and it was fine. And mostly neurologically intact, I would say probably after the fall. I don't know. My family might say, well, that fall, made him a little wackier. But that's when you're like, holy cow, I really need to give some consideration. And you might say, up until that point, I'm this healthy guy. I don't have a lot of like, if you're healthy and you don't have a lot of pre-existing conditions, right? You might say, well, of course I'm insurable. I'll just buy it right when I think I need it. The problem is that like every day that you live, you're probably picking up some pre-existing condition or something that adversely affects your insurability. There's never a time as good, for example, speaking from a disability insurance perspective, as when you're young and healthy to go get your disability insurance and then just to monitor it throughout your life. And I don't sell insurance, but that's just something that I learned myself. And I try to like advocate young, healthy people, go, if there's someone depending on your income, go get disability insurance because you don't know the day you're going to need it.
Let's shift gears and talk about the unspoken battles. Outside of the operating room, you also have to fight the system, the insurance companies, I would suppose, bureaucracy, a lot of red tape to deliver that proper and necessary care for the patient.
I'd say there are a couple of common situations. Okay, patient comes to the office, they have an injury. Let's say it happened at work. And they say, I had a slip and fall at work. I was carrying a pot of soup at a deli and I slipped. And this is a common example. Patient said, I work at the deli carrying a pot of soup. Someone had spilled soup before me. I slipped and fell. and I injured myself. And I say, okay, let's get you started. You need imaging because you've got findings of radiculopathy on exam. You need medication. You need some work restrictions. You need to get started in therapy. Let's figure out what's going on. So in that room, I've got myself, the patient, and we're just treating as we treat. Now, there's a whole world outside of that room that I'm not privy to necessarily, and that adversely affects the progress of that patient through the healthcare system. So what do I mean? So I treat a number of patients, some of whom do not speak English as their primary language. They might speak Polish or Spanish or another language. And some of the common problems that we run into, there are some from an employer perspective. And you say, like, what are those problems? And I'm not privy to these at the beginning, but they become apparent later on. And I have no way to control them. So this is common. And you'd say, 2025, how can this be common? One common occurrence is that employee has been being paid in cash and is off the books for that employer. That patient has a witnessed fall at work and then says, an ambulance took me away, a witnessed fall at work. And the employer said, that patient never worked here. And then they said, well, all these 3 workers witnessed me falling. And those workers who are living in their own fear of job loss will say, no, that patient never worked here. And you'd say, is that really true? Is that possible in 2025? Yes, it's possible. I saw it this year. Another common occurrence, more common than you would think. Patient gets injured at work, has a fall. Employer maybe has workman's compensation insurance. Patient says, I need to seek care. Can I get a copy of the insurance? Employer pulls them aside and said, look, my premium will probably go up if I file a claim. And so just go to the ER, tell them that you fell at home, get the treatment, and then I'll reimburse you whatever's not covered. Well, from that employer's perspective, it may sound good. You may be saying, okay, that the patient's going to get treatment. It'll obviate my insurance premium potential increase, et cetera. But what ends up happening is, the medical record is inaccurate. And the patient will later come to me and say, I had this injury at work, and now you've got a discrepancy in the medical record, which is not my fight to fight, but it is a barrier in terms of patient receiving treatment. And B, at some point, the health insurer that was being used to pay for the care becomes aware that this was an injury at work.
It's an insurance fraud.
It's insurance fraud. Exactly. Or the employer who is super willing to cover the bills on the day of the injury, when the bills actually come due, the employer's like, I'm not willing to cover those bills. I'm sorry. And so there are, in 2025, instances that I've already seen where the employer presents a barrier to care. And then the other part is from an insurer perspective. Same situation of an injured worker. Let's say the employer shares the insurance information, patient comes in, and we say there's a need for care. Not everybody needs care, but some people need care, and we're going to go ahead and provide that care. Well, in Illinois, there's this utilization review process for workman's compensation. I might say, Greg, you look injured. You've got an L5 radiculopathy. You need an MRI. I'm a spine surgeon. I feel pretty confident in the fact that you've got weakness in your big toe and you've got a matching sensory pattern. And utilization review means that I will send this. The insurer invokes utilization review. And the utilization review means that they have to find any doctor with a license, often not in Illinois, sometimes in Illinois through licensed reciprocity, but rarely in Illinois, might be a retired family practice doctor or an anesthesiologist. And that guy says, doesn't meet ODG criteria. Sokolowski might be a spine surgeon, but it's 5 days post-injury. The patient might have a radiculopathy and a foot drop, but we're not approving the MRI. And here's the kicker. If I don't appeal that denial within 30 days, treatment ends. If the doctor misses that one fax of UR denial, now there's a huge barrier to overcome. So when I come to the office every day, I get UR reviews. Some are certified. They come off the fax machine. Off the fax machine in 2025. Denial of MRI. Denial of physical therapy. Approval of a medicine. Denial of another medicine. And a significant portion of my time pre-clinically every day, I get there early, I review the notes, etc., is filing appeals, because if I don't file an appeal, the insurer says, okay, we have the opportunity for a blanket denial. We've invoked utilization review. And when you file an appeal, they're supposed to get a doctor of the same specialty as you to review the case. Okay, 2025, doctor of the same specialty as me. Who's reviewing it? Retired 83-year-old orthopedic surgeon in South Dakota. And you'd say, no way, that's crazy. How can that be? Yes, that's who is doing the appeal. Second is, I'm a spine doctor, right? And so let's say you fractured your tibia. Okay, there's no ambiguity. You get tibia fracture. It's hard for someone to deny that tibia fracture is there. Radiologist has read it as a tibia fracture. It's hard for someone to say, no, there's no tibia fracture, right? So it's hard to do a denial. Well, in spine, you can have a disc herniation. Let's say you've got a disc herniation L5S1. Company can send you for an independent medical examination with a doctor, and that doctor can say, yeah, the disc herniation's there, but it's likely pre-existing. Care denied. And now, because someone can say that it's likely pre-existing, you now have another battle to fight with the insurer. And that's a battle that I'm just the doctor. I just write the notes. I say, really, no, Greg has an L5 radiculopathy. He tells me temporally he didn't have a drop foot yesterday. He had this injury at work. He now has a drop foot. He's got new numbness he didn't have yesterday. He never had an MRI before. It seems to me that it's not pre-existing. So I just write my, response. No, I think, it shows I respectfully disagree with Dr. So-and-so. Whatever. But if that patient doesn't have someone fighting for them beyond the scenes, beyond my scope, that patient, the doctor might say, back to work full duty. And the patient's like, holy crap, I can barely do restricted duty. How can I go back to work full duty? So there are things that I can do in my clinic. I can treat you. I can get you a brace. I can give you an injection. Because I have a therapy clinic, I can start your therapy even before the documentation's in if you need therapy. I could give you a work note, but I have no control over the insurer UR process other than diligently filing my appeals and generating paperwork. And I have no control over what happens at that IME where someone can say, yeah, the radiologist read that as a disc herniation, but, probably pre-existing, or that disc herniation, or the patient had back pain 3 years ago before. Certainly, this is all a continuation of this pre-existing back pain.
You just said that those patients, they need somebody outside of the confines of your clinic to actually fight for them. And the question I get very often, and sometimes I get it too often, is the typical question, well, do I need a lawyer? Right? I had an accident, this and that happened to me, I'm treating with so-and-so, and do I need a lawyer? Well, I hope that whoever is watching this podcast or listening now understands quite well that there's a job cut out for everybody. For you, the surgeon, for the physical therapy place, for your primary physician, and there's a job cut out for the attorney. And everybody can only take it so far.
Yeah, I think that it's important to note that the doctor does not have insight into a patient's legal case. A lot of times people will think that I have some insight into the machinations of their work comp case. I don't. I just see you, I examine you, and I write a note. Now I can write that note with an exclamation point like Greg needs care, but I don't have the ability to handle anything beyond the provision of clinical medicine. And I can't offer legal advice. People will say, should I get a lawyer? I say, I have no idea. I don't know. I have no idea. I'm not qualified to make a legal assessment of your case. Because I, frankly, am not qualified to make any such legal assessment. So I don't have any, one thing I wish I could tell all the patients, I don't have any insight into what happens behind the counter at your insurance company, or I have no insight into what's going to happen at your independent medical exam. I just tell patients, be truthful, take all of your records, eliminate the opportunity for your medical examiner to say, I didn't have the records. Take your records. Eliminate the opportunity for the examiner to say, I didn't review the images. Go take him or her the CD of your images so that doctor can look at your images and see the same thing that the radiologist is seeing, that I'm seeing, And, the IME doctor has a heart too and probably would like to see you get better. But if you create an opportunity where someone can deny you care, people will take that opportunity because, and that's not due to maliciousness, but if a doctor can say like, well, I don't have the records. Sure. Yes, it's true. The doctor cannot make a recommendation absent a complete set of records. The problem is that now that patient is in limbo waiting for somebody somewhere at some time to review the records, and treatment like Vichy, it just hangs in Polish or just in suspended animation waiting for something to happen. There's this perception that people just want to linger for years not working and that it's some benefit to them. But people generally want to go back to work. People like making overtime money. People like working hard. People get satisfaction from working. My patients want to go back to work. Nobody wants to linger in this like suspended state where they can't plan for their future, et cetera. People want to go back, generally speaking. I'm sure that there are a few bad apples out there, but the people who are the bad apples, we don't treat. There's no benefit to me treating them. I'm not going to propose surgery to someone who's not going to get better. So generally, we as humans want to go be productive. We want to move them along. I'll do everything I can to move them along. We work within the system to the best of the best that we can. I've been doing it for a long time. This is my 18th year in practice. And so there's a lot of paperwork involved in being a doctor in 2025, and there are a lot of fax machine and faxing this and that back and forth, and okay, so we do it. It's fine.
What's up with the fax machines in 2025? Anytime I'm being asked to fax something, and it mostly comes up in the topic of medical records and treatment and so on, I always make a joke that, come on, can we just move to email or something else, some cloud link? Give me something else other than ask me for the fax. You won't be able to see anything I fax over anyhow.
I'm not a big social media guy, but there's that AMSR, where people like the sounds, the soothing sounds and all that stuff. There's something, I guess, physically satisfying about holding a fax, putting it through here in the little
feeding it through the machine,
and then getting the beep successful at the end. Yeah, people feel that's like somehow in the human evolutionary process that has become rewarding it gives a dopamine hit or something.
Do you have any pet peeves, any tips for PI attorneys, personal injury attorneys, that you wish they would do differently?
That would be an excellent question for my office staff, to be honest, Greg, because I made the decision. This is going to sound a little bit strange, but I don't directly communicate with attorneys really for anything in the office, because people say, if attorney from the plaintiff side or the defense side calls me and says, hey, what about this, in whatever capacity, if I was an IME examiner or a treater or whatever, people infer that there's some sort of a deal between the doctor and the attorney. So around 2020 or maybe even earlier, I just said, look, I am going to follow these strict rules. I don't email any attorneys. I just don't. I don't communicate with attorneys. When attorneys call the office, which I presume they do because we get all these subpoenas for medical records from one side or the other, or they schedule depositions, I have no knowledge. Yesterday I did a deposition. The attorney said, where did you get this report? I said, I have no idea. My staff gave me this chart for this deposition. Gave it to me Friday as I was walking out the door, said there's a deposition Monday, review the chart. I don't know. And that's an unsatisfying answer to the people at the deposition, but I am completely removed from the attorney process. Patients are like, oh, I'm frustrated with my attorney, I'm happy with my attorney. I say, I don't want to hear it. I don't want to hear it, because I don't want any situation to arise where the care for my patient is hindered because somebody perceives that I have something to benefit from working with the relationship. So we kind of follow, there's this wall. People are like, oh, do you hang around socially with attorneys? I'm no, I don't really hang around socially with attorneys. I don't hang around socially with doctors either. Kind of a social dud maybe, but I do that consciously so that nobody infers a bias or a conflict of interest or whatever. I am sure that if you were to ask my staff, is this person grumpy or is this person nice, or does this person call right before they need something, or is this person whatever, responsive? Sometimes we get subpoenas that are misspelled or the date of birth is wrong or whatever, and so we have to call and have them correct the subpoena. Or I know that the staff has said attorneys get mad that we don't accept service by email. We're like, the Postal Service exists. Those people need jobs. Send a certified letter. But that's really because we took those measures to make sure that we don't want to be in the business of emailing any side. So we say, don't email us. We don't accept service by email. You want a narrative report? Send us a letter, put an envelope, send it certified, and get it. And I got to say, my Postal Service employee, I've noticed that she's built up her shoulders and her arms over time, carrying those certified letters to her office.
I think the fact that you don't have an answer to my question is a testament to the effectiveness of your strict no communication policy.
Yeah, I would say so. Maybe everybody's out there like, gosh, Sokolowski's a grouch, but it's okay. I do that specifically because I'm in the business of patient care. That's it. There are so many things outside of patient care that I can't control. I can't even begin to control. And I think if people thought I had a conflict of interest somehow, it would adversely affect my patients in some way. And I don't want to take that chance.
A few minutes ago, you brought up an interesting point, how your patients, they don't want to linger around and get treated forever. But the question that comes to mind, how do you know? How do you tell apart in what way from somebody who truly needs more physical therapy sessions and more treatment from those who may be exaggerating their symptoms?
So some patients who would exaggerate their symptoms are often referred to as malingering. Patients who have like secondary gain, something to gain beyond simply recovery from not returning to productive employment or whatever. And there are some patients certainly who malinger, but patients who have an inclination to malinger, for example, they say like, I need more medicine. I don't want to go back to work, things like that. Again, I don't want to like overemphasize this point. I've been doing this for 18 years. So in those situations, I just say, look, I'm not the doctor for you. And what's interesting is when you tell someone you're not the doctor for them, that makes them want you to be their doctor more. If you say, I'm not going to do your surgery, they're like, no, I really want you to do my surgery. I'm not going to do your surgery. So what I've done, and this is the benefit of being in solo practice by myself. I've been by myself since 2010. So this is 15 years of by myself. I don't have any partners, I don't have any financial targets to meet. I don't have any thresholds to meet. There's nobody telling me you have to do X number of surgeries a day. I don't have an employer to keep happy. And so if someone has obvious secondary gain, if it looks to me like there's obvious secondary gain, I don't treat them. Now, are there some patients are there some things we can use to assess for secondary gain where it's less ambiguous, where it's more ambiguous? So sometimes it's obvious, right? If someone tells me, Mark, I'm not going back to work, I'm saying, well, probably not the doctor for you because I got to get you back to work. If secondary gain is not obvious, there are some Waddell tests. We can look for non-anatomic sources of pain. It's interesting because there was literature to say like these Waddell tests show you who's simulating with spine pain. But then years later, there was a paper that said these Waddell tests are not valid anyway. So really, if a patient has non-anatomic presentation of pain, like if you have L5 radiculopathy, but there's no explanation for an L5 radiculopathy. Your MRI is totally clean. Your EMG is clean. You don't have a peroneal nerve palsy. You don't have neuropathy. You don't have any other etiology for an L5 neuropathy. I'm probably not going to make you better. And one of the upsides, but also one of the downsides of being in solo practice is I gotta eat, right? And I gotta feed my kids. So I gotta hit some home runs, right? If I'm hitting just if I'm having a bunch of surgeries with crappy outcomes that people don't get better, I go out of business, right? So the goal is I want to operate on people I'm going to make better because that person's going to positively reflect upon their experience in my office. So over the years, I don't treat people who I think are not going to get better. And that eliminates 90% of malingerers. And those people who have a non-anatomic source of pain, I don't offer any invasive management. It'd be silly to do invasive management when there's nothing to treat because you're going to have a dissatisfied patient who's then going to be grumpy when they recall their time with me. And that person will be a negative referral source for me for the future.
I would think that the idea of getting cut open and have my spine operated unnecessarily because I'm faking it would scare away pretty much everyone, right?
I think it does. I mean, like I said, I don't like going to the doctor. I sure as hell don't want surgery that I don't want. There's this joke that a patient once told me, and it's, how do you find a spine surgeon on the beach? And he's the guy without a scar on his back, right? Because spine surgery is tough to recover from. And a lot of people need spine surgery. But I would say generally, the spine surgical community wants to operate on people who are going to get better, because there's no point in doing a surgery that imparts risk upon a patient if the benefit does not outweigh the risk.
So what do you tell somebody who says, doctor, everything hurts?
Say that, unfortunately, well, it's a good question, because a lot of people have multiple sites of pain, right? And so if someone truly has everything hurt, there's probably not discrete pathology that I can treat. Now, if someone has everything hurt, could they have fibromyalgia? Could they have a rheumatologic diagnosis? Yes. So if someone has pain that is not discretely treatable, and again, overwhelming majority of people who see a spine surgeon, even with discrete pain, don't get spine surgery. People get better, overwhelming majority, without surgery. So you can have a disc herniation, 90% chance you're going to get better without surgery. You can have a compression fracture, exceedingly likely you're going to get better without an intervention. But someone who has pain truly everywhere, and the way that we'll see is like with everybody fills out a pain diagram when they come to the visit. And if there's pain everywhere, I'll do a same exam. Maybe there's a missed cervical myopathy responsible for the pain. Maybe there's a missed diabetic neuropathy responsible for the pain. I'll do same honest, good exam for them. But if there's someone that doesn't have discrete pain or something I can't do, I really like to refer people out. And here in Chicago, I'm a solo practice guy at Harlem and North, but around me are University of Illinois, Chicago, University of Chicago, Rush, Loyola, and Northwestern, 5 powerhouse academic institutions. So I'll often say, look, you have a problem I can't figure out. I'm just a guy at Harlem and North, a community spine surgeon. Let me send you to university, or let me send you to a rheumatologist, or let me send you somewhere else for someone else to take a look. And sometimes a rheumatologist will say, you missed this rheumatologic diagnosis. I'm glad you sent them over. And sometimes they'll send them to a pain specialist or whatever, and we can fix it. Or sometimes Rostofinsky, the psychologist. But if we can't figure it out, I just say openly, I can't figure it out. I can't make you better. I think it's good. It's humbling, but it's good as a doctor to say, I can't fix everything, and I'm sorry, I can't fix it. Let me see if I can send you to somebody who might have a fresh set of eyes to take a look at it.
That is very interesting. In my conversations with people who got injured spines, injured backs, quite often they don't want to go and see an orthopedic surgeon like yourself because they're worried, he's going to want to cut me open, right? On the first visit. Of course, he's going to recommend the surgery. He's a surgeon. I don't want to see the guy. I would rather try something more conservative. So do you think there's this misconception about how quickly an orthopedic surgeon wants to operate on somebody's back?
Yeah, I think that's true for orthopedic. So I think that's true for all of orthopedic surgery that's not traumatic. So if you have a fracture, so first of all, many fractures are treated non-operatively. So just a fracture alone doesn't mean you're heading for surgery. There are radiographic criteria and clinical criteria for which fractures get surgery. But if you remove people with bony fractures, you have a meniscal tear, you have a rotator cuff tear, you've got a disc herniation, you have a very good chance of improving your function, relieving your pain non-operatively. You can have a rotator cuff tear, take some medicine, do some therapy, and be fine. You might need a shoulder corticosteroid injection. You might be fine. It's probably a minority of patients, especially when you get into older patients. It's a minority of patients that require surgery. Same thing. You can have a meniscal tear and otherwise arthritic knee. A little bit of therapy, fine. You can get an injection. Maybe that helps you. And maybe a minority of those patients will require surgery. Same thing with a disc herniation. Even if you come in and you say, Mark, I've got crazy radiculopathy. It's going down my leg. It's keeping me awake at night. I'm still going to say, Greg, let's try these measures short of surgery first. Because if you're going to get better short of surgery, there's no benefit in me operating on you and getting you better. Why take a road that zigzags through surgery approval, recovery therapy, if you can just go the recovery road? So not everything needs a knife. Sometimes when I have a new patient and I can see that they're squeamish, I'll call them in. And we do this goofy thing in my clinic where I call every patient back myself and I announce their name game show style. So if I was seeing you, I'd be like, Mr. Czubernat, as I call you back. and that's not an exaggeration. I call everybody back the same way. And the reason that I do it is A, it's silly and it's kind of stress reliever, but B, there's like a 30-foot walk to the waiting room and I can watch you walk. I walk ahead of you and patients are always like, they're like, I can't keep up with you. And I always say, it's concurrencia, it's not a race, it's not a race. And I just turn around at the back and I want to watch you walk because seeing your gait pattern will give me a lot of insight into your problem. But when I see someone who's still kind of squeamish and kind of giving me that side eye, like, I'm seeing a surgeon, this is horrible, I'll say, Panie jest gotowy kroić dzisiaj? Are you ready to be cut today? And they'll say, what? And I'll say, just kidding here, and tell me and then I put them in the room and then we start.
So you disarm them.
Yeah, disarm them. And then the other thing that disarms them, this isn't really an answer to your question, but 15 years ago, I realized that like when a patient walks in the room, the most disarming thing is I do the same thing over and over. If you were to follow me for the day, you'd be like, oh my God, this guy's just got one routine. I call you game show style. I bring you back to the room. I watch you walk. And then if you're a new patient, I throw the chart on the desk and I say, if they're an English speaking patient, I just say, tell me your story. And then I shut up and I just listen. And the average patient speaks 90 to 120 seconds uninterrupted and feels like they told you their whole story. Or in Polish, I say, w czym mogę pomóc, right? And what can I help you with? And they will speak for 90 to 120 seconds, but they will rate the satisfaction of that visit as, holy crap, the doctor listened to me and I got everything out.
That is fascinating. That basically 2 minutes, right?
Yeah.
You give them 2 minutes to tell their story and they feel heard.
Yeah, sometimes that goes off the rails and it goes 28 minutes. But generally speaking, people think in that waiting room what they want to say. It's important to me to say, I have this, these are the important, whatever. And then I ask the follow-up questions or whatever. But if I just shut up for that 90 to 120 seconds, I do that little casual chart toss and say, tell me your story, or w czym mogę pomóc, that people feel like, wow, I got my story out. I got to say what I wanted to say because and so then you might ask a follow-up question. Well, did you ever have pain like this before? What else do you notice? What can't you do? But people just want to tell you their thing and you just let them tell you their thing and they're happy. They're like, this is the first guy that listened to me.
That's fascinating. I typically tell people, listen, I need to get some solid answers to the questions I have, but I promise you as soon as I have what I need to evaluate your case, you will have a chance to tell me your story. And that disarms people. It puts them at ease.
Yeah, I 100% agree. And that's something I didn't do in the start of my practice. In the start of my practice, I'd be like, oh, tell me about your back pain. Tell me about your leg pain. Tell me, is it numb? Is it this? All these like leading questions that pinhole your patient into giving what you want to know, because as the doctor, you think this is more efficient. But in reality, the most efficient thing is if Greg is here because his foot's numb, just let Greg say that he's here because his foot's numb. And then you figure out why the hell is his foot numb?
Can you share a story of a patient whose recovery was simply nothing short of a miracle? Somebody who defied all odds.
Okay, so we operate on some people, right? And many of them have good outcomes. They recover lost motor function, sensory function, etc. So those are good outcomes of spine surgery. Not, I wouldn't say like miraculous, right? If you said, Mark, what's the most amazing, like wild stuff that you've seen in your practice? Turns out it had nothing to do with me. And I was kind of thinking about this the other day. The stuff is more that I've been a witness to more than an active participant in. So like one example, I started in practice 18 years ago, and there's a lady who's about 50 years old came to see me for back pain. And she treated with me. She said at the first visit, oh, I had this history not too long ago of uterine cancer, endometrial cancer. I had a hysterectomy. They told me it was stage 1 or stage 2, but they were able. The margins were wide. They removed my uterus and all the lymph nodes, etc. All the cancer stuff that I'm not 100% familiar with. And they told me it's likely a cure, great. And so she had some back stuff. So treated her with like some physical therapy. We got like some imaging, maybe x-rays, and she would come to see me once a year, and she had back pain, and she's, responds to therapy and some medications once a year, once every other year. She had like a flare up of back pain. She'd come to see me. And I have some patients like that, like especially like some Polish patients or that like to come to the doctor, once a year, once every 2 years for a checkup on their back pain. And I do a neurologic exam and I say, I think it's equivalent to last time. Maybe we don't need imaging or whatever. And then I remember she came back like 10 years into treatment. And on a visit, she's like, God, my back is killing me. And she's like a 60-year-old thin lady and mid-back pain. So I think like osteoporotic compression fracture. We get an x-ray, doesn't really show anything. And I say, maybe an occult fracture. And so we MRI her thoracic spine because the pain was just greater than it had been in years past. And the spine doesn't show anything negative, but the radiologist notes a mass in her lung. And so say, okay, and we go back and we look at the MRI we got a few years, like 5 years ago, and there's no lung mass. And so I say, okay, well, interesting. And I say to her, and you'd say like, how often does a spine surgeon diagnose a tumor? Well, spine surgeons order a lot of imaging. It would be surprising to you the number of times in all the years that a spine surgeon that I've been practicing and other spine surgeons find unrelated, incidentally identified masses on imaging.
That are completely somewhere else other than your spine.
Completely somewhere else outside of your spine. Or you might find metastatic disease in the spine and you have to break bad news to patients, which was a medical school class, breaking bad news. If I knew how often you had to break bad news, you'd say like, wow, I'm a spine surgeon, I never have to break bad news. Well, yeah, you do. So anyway, she had this mass in her lung. We sent her to a pulmonologist. Pulmonologist biopsies her lung. And it's metastatic uterine cancer. And it's like, holy crap, this woman who had endometrial cancer years and years earlier, thought she was cancer-free for like 15 years, has this metastatic cancer in her lung. It's uterine cancer. So she ultimately goes, has this lung resection, chemotherapy, comes in to see me in like a couple of years after that. And she looks like she's on death's door, like super skinny, has back pain, but everything hurts because she's in the midst of chemotherapy, no hair, just makes you want to cry when you see her. The reason she went through chemotherapy was the thought was that if she had metastasized to her lung, all these years, she might have micrometastases elsewhere. The chemotherapy was to treat. And she ultimately developed breast cancer, had to go through mastectomy, chemotherapy, radiation. Greg, I saw her 2 weeks ago, 5 years, cancer-free, normal, healthy, bopping around, 60-some-year-old lady. And I'm like, dude, I am a witness to a miracle from the man upstairs. This doesn't have anything to do with me. This is the man upstairs. I got to be a witness to like a miracle. So yeah, spine surgery's cool and stuff, but that's not it. That's cool. That's amazing. That like this woman who is literally like so frail, so in the throes of chemotherapy, like I seriously thought this was the last time I would ever see her when she came for her visit 5 years ago. 5 years later, she's cancer-free. She's complaining about like low back pain. I'm like, dude, this is amazing that you're complaining about low back pain because this has nothing to do with your cancer. You're back to like a healthy life. So the miracles are from God. The miracles have nothing to do with me. The miraculous recovery is from the big guy. I'm just like, in the privileged position of being able to like witness people through hard times in life get better.
I'm sure that for every happy ending story like that one you just mentioned, there's another one where the outcome wasn't as expected, despite the proper care and despite all the dedication of everyone who was involved. Do you recall a story like that?
I'd say, what are the things that linger in a surgeon's mind? The things that linger in a surgeon's mind are post-operative complications. And, if someone woke you up in the middle of the night and said, or woke me up in the middle of the night and said, Mark, tell me your 10 best surgical outcomes and tell me your 10 things that like happened post-operatively that you worry about. Someone had a heart attack or something along those lines. That you always human nature is to perseverate the tough situations, right? So I would say that with experience, and probably comes a little bit more of a tendency to work up the patients preoperatively. For example, if someone has sometimes you can have a heart attack postoperatively, and you can say, gosh,
is that common?
No, rare. But let's say someone has a heart attack postoperatively, and you'd say, well, they met criteria from an anesthesia perspective. They got an EKG beforehand. They didn't have any risk factors. There was no need for an echocardiogram. I might then alter my practice and insist on an echocardiogram for every patient that seems to have the same type of thing. And the anesthesia department might say, Mark, you don't need an echocardiogram on this patient. And I'd say, yeah, but we followed the anesthesia criteria beforehand and got an EKG. And then this guy had a heart attack postoperatively. Let's see what we can do to prevent it. Or we might say, okay, you might, when closing a wound, you might do it in 2 layers. And that's fine. But then if you have a wound that didn't heal with 2 layers, I might do the next 5 cases, I might do a 4-layer closure. I might sit there and do overkill, because the natural tendency of humans is to perseverate on things that didn't go well and to try to avoid those in the future. So there might be, you might say this patient I did a lumbar fusion on, but he still had back pain after surgery. What could I do the next time that helps me better identify the pain generator? And so if I have another patient that reminds me of this patient, I might say, gosh, I'm going to order this test called a provocative discogram. And a provocative discogram is a crappy test, because patient goes to a pain doctor. It's controversial a little bit. The doctor puts saline into each of the disc levels and will wake you up and say, Greg, is that your usual pain? And you're like, yes, it's my usual pain. Stop. And then they'll give another level and they'll see if it's that your usual pain. And it's a little bit of a torture test. But if you have someone that you fuse for back pain and that person still has back pain, you say, well, what could I have done different? And maybe the next few I'd order a provocative discogram on, until you start to get, rack up all your good outcomes again, your 90% good outcomes. And then you say, okay, maybe I don't need to do that. And so it's there are tough days in surgery. There are surgeries that take longer. There are untoward complications. There are just all the human aspects of medicine. When you walk out of that operating room, the one thing that professor taught me years ago in my training is you're facing the family. They only care about one thing. That you can say, oh, we did the surgery successfully. I put the pedicle screws in. We had excellent instrumentation, blah, blah, blah. The patient just wants to hear, Greg is alive and moving. And then you could just say whatever other gobbledygook you want. They don't care. They're not going to remember it. They want to know that you're alive and moving and that it went well. And so the most human, the most vulnerable interaction is when you're going to the waiting room, that family member is waiting with anticipation for their family, and you just want to deliver them good news. So the tendency is you're like, how do I put all the odds in my favor, have good days? And man, it feels good to walk in that waiting room, to see, let's say your loved one's having surgery, walk in, the patient's family sees, their eyes instantly light up. They want to know, is Greg okay? And then you say, Greg's awake and moving everything. And you could literally do a jig, do everything else. They're not going to remember it. They're going to remember that Greg is awake and moving everything. And that's it. That's it. That's what people want to know after spine surgery. My loved one is awake and moving everything. Now, do they go on to successful fusion? All that stuff. That takes time and all that stuff. But the most intimate moment post-operatively is with that family member when you're like, it went okay. And you want those are such a dopamine hit for the surgeon to give and such a dopamine hit for the family member to receive, that you optimize your practice for delivering good news.
At what point during the surgery you start thinking about the script, about the things you're going to say to the family that you know is waiting?
I think the part that just when the major part's over, there's when the big part of the surgery is over, whether it's a little surgery or a big surgery, there's this internal sigh of relief. Okay, hard part's over. Let's close this puppy up. And it's good. And it's funny because oftentimes the surgical assistants are really quick and amazing closers. A lot of them are surgeons, people who are surgeons in Russia or in Ukraine or in Eastern Europe or Poland or whatever. And some of them have been the surgical assistants that they were doctors in whatever country that they were in, and they come to America and they work as surgical assistants here because they didn't go through all the testing and redo residency or whatever. And they were like straight up vascular surgeons in their own country. They're amazing, right? And so it's, as we're closing, they'll say like, Sokolowski, dude, you're closing too slowly. Do you want me to do it? I'll do a better job or whatever. And they'll like criticize my little closure technique. Or if someone has a back tattoo and I'm like, oh my goodness, we have to like sew this guy up for like 2 hours to get every little aspect of this tattoo. They're like, let me guide you through the final skin closure. And that's when like there's levity and all that stuff, because you're like the hard part's over. Nobody admits it. And I've been very fortunate because I've had the same people in the operating room, the same nurses in the operating room at least one of the hospitals I go to for 17 years. They saw me from little boy Mark walking in day one to now like Mark with the progressively increasing bald spot at this point. And they've seen me like, kind of like get my wings and all that other stuff. And everybody's like, is everybody kind of knows when like the hardest part's over and you're like, okay, there's the internal sigh of relief. It's going to be like, it's good. And then I neurologically monitor all my cases. There's an SSEP, a neuromonitoring technician in the room who's monitoring electrical signals from the spine during all my cases. And I just started doing that. It's a little bit overkill, but I've been doing that ever since day one. I monitor all my cases, and the surgery's good when they're like, Sokolowski, no changes. And that means there's no electrical changes pre and post-operatively. Patient is neurologically stable. Or if they're like, oh, it's actually, the signal got a little bit better or whatever, which is rare. But generally they say no changes. You know that your patient, it's like patient did well. And that's 99% of cases or whatever. But it's just good. And when you have there's like a warm and fuzzy feeling to the OR. When you're young, you have like something to prove and you want to like convince these people that you're good, and like there's a lot of like tension. And as you get to be like an older guy, you're like these people. Everybody's rooting for you in the OR. Nobody wants the surgeon to have a bad day. Everybody's rooting for you. Everybody's like, how's your family? All this stuff. Like, these are the same people who've been there for a long time. And when you're young and you have something to prove, it's a lot more stressful. When you're older and like, people know the silly things you say in surgery or whatever. It's like, it just becomes a pleasant day at work.
I wanted to go back to the tattoo situation you just mentioned. I only heard that there's only one rule with respect to tattoos. You should get something that will not get you killed in prison. I don't know whether that's true or not. And now I guess I can add a second rule to it. Whatever you get, make sure if you ever need a surgery, right? That the surgeon can put it back together. So don't get something too complex.
Yes, I would say my advice to tattoo seekers is, look, the L4-5 level and the L5S1 level are the most commonly herniated levels. Just if you're going to put it over the lumbosacral spine, just put it off the midline and you'll have a nicer looking tattoo at the end. Or put it higher up on your spine. But if you got to put it there, okay, we'll sew it up.
So no lower back tattoos, I guess, right?
Yeah, if you go lower back tattoo, it'll just take us a little longer to sew it up. We'll do our best and we'll try to make it work. I just have that, that meme that the guy has the neck tattoo and it says no regrets. Regrets is misspelled.
I did see that one.
Yeah. So I'm going to try to make sure that the letters line up as I sew it up.
How does it feel to have your hands in the operating room on somebody's spine, on somebody's future ability to walk, to work, to have a normal life?
It's surprisingly kind of anticlimactic. We know the anatomy. We peel the muscles back or approach it if we're approaching it posteriorly, or we approach it from the front in between muscles. And it's cool. Like the anatomy is just cool. It's amazing. When I think about one of my favorite surgeries to do, it's the anterior retroperineal approach to L5S1. And
where's that on the body?
That's right here at the lumbosacral junction, and we're going through the belly. And a vascular surgeon opens up the tummy, often through like a bikini style incision, and through this little incision moves the entire contents of the bowels over in this sac, the peritoneum, And there is the coolest anatomy that just makes my heart skip a beat every time. The aorta, the descending aorta, and the inferior vena cava coming to and from your heart splits at L4, L5, and right in the crotch of that split into the external iliac vessels, staring at you is the L5S1 disc. It's awesome. And there, when you're taking out that degenerative disc right between these two vascular pipes, after a beautiful exposure by the vascular surgeon through a relatively tiny incision, and you're putting in these big instruments through the belly and taking out that L5S1 disc and putting in a metal implant and jacking that puppy open and putting the screws in, that's awesome. It's a feeling I will never, ever, ever get over. It's amazing.
When I hear spine surgery, I typically envision somebody laying flat on their tummy and the surgeon working on the person's back. But you're telling me there's plenty of other spine surgeries that happen when the patient is on their back while you're going through the tummy.
That's right. Going through the front of the spine is crazily elegant. It's awesome. The majority of surgeries happen through the back. And when you go through the back, there's muscle there. There's big paraspinal musculature. It can bleed a little bit. When you go through the front, like in the neck or in the belly, it can be a bloodless, virtually bloodless surgery between muscle groups. When we go through the neck, we go between the sternocleidomastoid and the strap muscles, and you put your finger down in this plane and you dissect with this little cotton dissector. And there is the spine. When you see it, when you move these things, it's beautiful. And the same thing in the belly. When the vascular surgeon moves aside that peritoneum and he exposes the spine, you see all the way through the abdominal cavity to the spine, and you see the vessels from the heart laying on the spine, and there in this shiny fascia over the spine, it like shines back from the OR light.
It sounds counterintuitive to approach the spine surgery through the front, moving all the intestines to the side. I would think it would be easier from the back.
It can be easier to go through the back depending upon the pathology. But if you have to take out the entire disc, you can get more of the disc under direct visualization by going through the front. It's awesome. And then 2/3 of the spine is the anterior two columns of the spine, the front two columns of the spine. There are 3 columns. The front 2 are in front of the spinal canal. So those are either accessible through the front of the neck or through the front of the belly.
Do people find it surprising that you tell them that their back surgery will happen through the belly?
I do, but it's actually often more minimally invasive than going through the back. It's muscle sparing as opposed to muscle splitting. Rather than splitting the muscle, we're going in between muscular planes. It's cool. And the belly surgery, I gotta say, it's props to the vascular surgeon. The vascular surgeon is the guy who opens the belly, who does the tricky work of opening the belly. He does all the hard work, and the spine surgeon comes in and gets all the glory. But it's the vascular surgeon who's the real hero in that case. It's awesome. It is just, when I see that spine through the belly, it's awesome. You can do powerful corrections through the belly. You can take out large amounts of disc. You can put in big implants in. It's crazy. It's good. It's thrilling, and it's powerful.
I've also did my due diligence, and I learned about your work with Cabbage. And I'm curious how you got started with that, and what was that first moment like when you thought, maybe there is something more to that story?
So the little bit of background I'll give is that I'm always a little bit of a tinkerer. Growing up, my parents were both engineers, and they would say, you can do whatever you want with your life, but it has to start with an engineering degree. And so we always would joke like, oh, we're going to become an artist with an engineering degree. My first job out of college was working for Philadelphia cream cheese.
Really?
And we were making Philadelphia cream cheese more spreadable by adjusting the moisture in the curd and whey components, putting an infrared sensor in, having a feedback loop to the centrifuge that divided curds and whey, and adjusting the moisture. The idea being that if you had consistent water content, Philly cream cheese, nationwide would be consistently spreadable.
So did you come up with the whipped cream cheese idea?
I didn't come up with anything other than adjusting a centrifuge through a feedback loop at a plant in Rupert, Idaho, a little town of 6,000 people, about 2.5 hours away from Salt Lake City. So that was my first job. But I've always had like this tinkering kind of mentality. And in the course of our practice, we treat a lot of patients from various ethnic groups, Polish, Hispanic, Asian, and a lot of them have these home remedies for treating pain. And one thing that kept coming up was that people said, when I have joint pain, I put cabbage leaves on my knees, my hips, my ankles, and it works. And I said, does it really work? So I would hear this over and over and over again. And we started hearing this in like 2013. And just to give you an idea how long it took me to get off my butt and do something about it, it was 2021. So 8 years of hearing this. But at some point, I just said, like, what is this cabbage, like this recurring cabbage leaf thing going on? And so I looked at it, I Googled it, did some research, and there's actually a study in like 2016 that looked at folks in nursing homes who had knee arthritis, and they compared usual care, which was like Voltaren gel or like oral anti-inflammatories, to applying cabbage leaves and wrapping them to their knees. And the people with cabbage leaves did better. Really? And it was like, what? This cabbage leaf, this hidden cabbage leaf. So then we said, all right, well, we're not going to sell cabbage leaves, right? But what do we do? You can't just walk around with like cabbage leaves on your joints. So we said, how do we come up with cabbage leaf extract? And I would talk to these Polish women. I'd say, like, what do you do with these cabbage leaves? And they'd say, oh, I take like a meat hammer, and I beat the cabbage leaves, and then I put it on my knees. And then other women would say, like, oh, you didn't know that's how we treat breast engorgement. You put cabbage leaves in if you are breastfeeding, and that's how you treat. And so there's all this data. Yes, there's data on breast engorgement for cabbage leaves. So it's like, holy crap, I just thought this was for Bigos, right? So we started doing cabbage. We hired a chemist to come up with a chemical engineer, but I don't know how to make a cabbage leaf extract formula that's like a skin cream. So I hired a chemist through Upwork, which is one of these job sites like Fiverr, Upwork, where you just say, I need to come up with a cabbage leaf lotion. And some chemist in some foreign country will say, I'm happy to do it. Here's my bid. You hire them, you pay them, and they do it. And they send you the formula. So then they sent us the formula, and they're like, okay, now we got the formula. What do we do with it? Got to find someone to manufacture it. So for about a year over lunch, I would call factories around the world that manufactured lotions and cosmetics and said, I'm the schmuck in Chicago. I've got this cabbage leaf formula. I need to make a lotion for it. And most people are like, dude, what? And just hang up the phone. Well, enter Korea, right? Home of Korean beauty, like ISO certified manufacturing facilities, contract manufacturing, and Korean factories have a lot of experience with cabbage leaf because of cabbage is like a vital part of the diet, kimchi, and also with it is a natural extract, fermented products. So we found a factory in Korea that agreed to make the first run of 10,000 tubes. And
10,000 tubes.
10,000 tubes.
How big is the tube? Like a toothpaste? Smaller?
Yeah, it's like a toothpaste tube. The minimum run is 10,000. And they say, wire over this money and we'll produce you these tubes. And I had never met this factory. And I was like, they all have good reviews. They contract for major beauty manufacturers.
How did you make that decision to wire them all the money without seeing them? Did you go and visit?
With trepidation. I was like, I may never see this money again.
Or the cabbage extract, right?
Yeah. But they said, send us whatever the initial investment is. You send us half of the production cost ahead of time. We'll produce it when we get around to it because it's a small batch, and you'll send the other half, and then we'll get it to America. In the meantime, design the packaging. So I was like, how in God's name do I design the packaging? So Upwork.com. And I put in, I need a packaging designer to help me design a logo, packaging. I need it to meet these requirements. We can't make these medical claims that we can't substantiate. Sure enough, some guy who's a packaging designer in Serbia says, I can do this. He bids on the project, comes up with the packaging. It takes us like 45 days back and forth to design the packaging, send it over to the factory in Korea. They say, we can get a packaging supplier to do all the stuff. We get the tube, we get the stuff. They send over some samples. The only indication I had that this was in fact going to result in something was that they sent over some samples.
How long did it take from the moment you wired the money and you had to wait to see the product to see if you got fooled or you actually are going to produce this stuff.
6 months of me saying to my kids, there may not be Thanksgiving this year, but 6 months. But then we got the product. It came in first batch of 10,000 tubes. And then we just started giving a tube to every one of our patients. And then we gave out some tubes at this Polish pielgrzymka. And then last year we gave out some tubes at this Biegnie Podległości or whatever. We just started giving out a lot of samples. I have no idea how to market a consumer product. I was in the chemical engineering division of Philadelphia Cream Cheese, not the marketing division. So we started doing it, and this thing just started to get legs of its own. And people are like, holy crap, this works. And we're like, well, how does it work? We did some additional research. There's like all these in these cruciferous vegetable family. So it turns out cabbage is in the mustard family, along with broccoli, cauliflower, all this stuff. And there are these phytonutrients which have natural anti-inflammatory benefits. It's actually like legit. And so we make the stuff. It sells. We have reordered from the Korean factory. We've reordered again. Our next batch is actually coming in. It's ready for shipment. It's on the vessel from Busan, Korea to Los Angeles for 14 days, which means it's coming in after the 25% tariffs hit. Ouch. But that's okay. Live and learn. And we'll pay our tariffs and then we'll have it. And
how many thousands of tubes you had to order this time?
Each order is 20,000. We do 20,000 batch orders, and then they produce those for us. Every time I wire the money over, though, it's always like, we'll get to it when we can, because we're a small client of theirs. And I'm always like, is it really going to work this time? Because they've never failed to deliver, but I always kind of worry, like, where am I sending this money? And it's funny because when you go to wire the money over, it says Korea North or Korea South. And I'm always like, I have this nightmare that I'll choose North Korea, and like the people coming to my door and arrest me for sending funds to North Korea. It's South Korea, I promise.
That is fascinating, but it shows that a surgeon who runs a very busy clinic, right, has time to come up with a product, to organize it. Sounds like from behind of your computer screen. Yeah,
I got it. All the credit goes to the Polish, Hispanic, and Asian patients that were like, cabbage leaves. Greg, it took me 8 years of hearing cabbage leaves to be like, all right, maybe there's something here with cabbage leaves.
That is a fascinating story. I'm even more amazed that you found the time to actually make it happen. That is spectacular.
My kids like to say, you can just do things. And the truth is, you can just do things. And the internet makes it, you could literally today say, I would like to do X. Go to Upwork.com, and there is somebody in this world, or Fiverr.com. I'm not a paid spokesman for these places, but for these websites, there is someone in this world with the skill set to do it for you. And then it's just a matter of like making a punch list and getting a bunch of no's until someone says, okay, that sounds crazy, but I'll do it. Here's the other tricky, let me just persevere on this Korea point, but I don't remember how exactly the formal names are, but I'm pretty sure the name for North Korea is the Democratic People's Republic of Korea. And I'm like, wait a minute, is that the good one or the bad one? The Democratic People's Republic? I don't know. It's tricky stuff. I was sweating. I still sweat. Make sure I don't choose the wrong one.
I'm super curious. What led you as spine surgeon to write a book, which I understand is a roadmap about making the right financial decisions? Immigrants to Investors, right?
That's right. Yeah, I think that what the inspiration was that I have a pretty large extended family. Many of us are children of immigrants. We're the first generation born in America, my generation. And a lot of our parents took a big risk, came from, in our case, Poland to America, and made this major life change in pursuit of better opportunities. But even though they made this life change that was itself like a huge risk, right? Coming to a new country, not speaking the language, no promise of employment or career success, they then tell us, in our case, for example, be conservative with your money. Don't invest. The stock market is risky. Put it in the bank. Get a CD. You're really doing great at 3.2% interest. Buy real estate direct, become a landlord in like a 3-flat or something. And a lot of those things, they're very well intentioned, but a lot of them don't jibe with what you hear in the American financial media, where it's like invest in the stock market. Over the last 100 years, there's been an average rate of return of 10%. Or you don't have to be a direct real estate investor. You can invest in other opportunities, or you don't need to work for a big company. You can work for yourselves. Our parents, in my generation, when we look at our parents were often super entrepreneurial, but yet then they tell us like, go work for a big company, have some job security and a good benefits package.
The stable paycheck.
Exactly. Right? Yes.
That's the myth of the stable paycheck.
Yes.
I had the same problem, and I don't want to call it a problem, but the same type of discussions with my relatives. What? You want to start your own law firm? What are you doing? Why don't you just go work for somebody and have a secure job?
Exactly.
There's no such a thing as secure job.
Exactly. 100% agree. And I think that people perceive that like that's the American way is to work for like a big corporation. But the reality is you're even more powerless than to control your career path. And then I say like, hey, yes, it's risky, but it's a fraction of the risk you took in like coming to America, right? It's a significantly lower risk.
That's a great analogy. Yeah. And I don't think they realize that, do they, when you talk to them?
No, not at all. And parents will often say, I worked so hard and took this risk so that you could have a better life. But a better life might mean entrepreneurialism. I remember when I went to college, my parents were like, you had to be an engineer. I knew I was going to be an engineer. If I told my mom, like in 1996, I'm going to go move to Palo Alto, live on a couch and code, my mom would be like, what the hell are you doing with your life? Right? But guess what? Leaving University of Illinois at the same exact time were the future founders of PayPal. They were there when I was there. Then I've listened to their story. They went to a couch in Palo Alto, coded, and they founded PayPal. Like, Americans know that you can take this entrepreneurial risk. And I don't know that a lot of us, children of immigrants, know that that's an option. And so the book was A, to say that's an option, and B, to say, look, here's the way that you can accumulate some wealth in America. It's okay to invest in the stock market. Don't leave your money in the bank at 0.1%. So I think there's a lot of misconception. And I think that the book was merely to say, hey, take a risk on yourself. These Americans know how to invest. Twitter is not the place to get your financial advice.
Or legal advice.
Yes.
Or medical advice.
Or medical or legal. And really, there is a way, there is this like roadmap that already exists. Nobody's marketing to the generation of immigrants. There's Dave Ramsey. There's like for medicine, we have a podcaster in our space that's like very focused on medicine. Dentists have one. I'm sure attorneys have one. Pilots have a financial podcast, but nobody is like talking to generation one born in America of immigrant parents. And I said, gosh, this is an unmet need.
You just have to be more open-minded and get educated, right? There's plenty of financial advisors and other licensed professionals who can advise you what and how to do with your money. But sometimes I feel like when I recommend a certain professional, whether it's a financial professional or a lawyer or a doctor, sometimes people think they're not ready. For example, common objection. Well, I will go see a financial advisor when I'm rich, right? I mean, that's not the point. It's like basically saying you will not hire a personal trainer until you're super fit. Well, that sort of defeats the purpose, right? You should have that person with you on your way there and help you get there faster.
And then once you have a plan, once you have something on paper, you go home and you follow it. The hardest part is putting it on paper. And so many people, myself included, are like, oh, it's right here. This is my retirement plan. I got it all right here. Yeah, that's great. But if it's not on paper, A, you're unlikely to adhere to it. And B, it's nice if like your family's kind of in on the financial plan, because if you got it all right here and you croak, it's not like great for the rest of the people. So it's kind of like put the plan on paper, because all this literature shows when you put something on paper, you're more likely to follow it. And if you can't put it on paper yourself, watch YouTube videos about how to come up with a financial plan or hire a financial advisor. And it's crazy. Like I'm not a financial advisor, but I just tell people, you don't have to reinvent the wheel. This system exists. Just go participate in it.
Drawing from all of those stories we heard today, from the trauma through recovery, even we discussed the power of the cabbage. What is one piece of advice that you would whisper into the ear of a person who experienced trauma, who was injured? What would you want them to know?
there is a very good chance you'll recover. And in the event you cannot recover on your own, there exists medical professionals to guide you to your recovery. And just because you're going to see a surgeon maybe, doesn't mean you're heading for surgery. There's still a very good chance for many common orthopedic problems that you will avoid surgical management.
Thank you very much for being here. This was spectacular, and I truly enjoyed our conversation.
Thank you very much. I thought this was great too. Thank you for having me, Greg. This is a super cool experience.
I am Greg Czubernat. Thank you for going off the record with me today. If you enjoyed this episode, subscribe for more conversations, and don't forget to visit Czubernatlaw.com to learn more about my work.
You know what's funny? Because I told my mom yesterday on this walk as I'm doing this podcast, and my mom said, "Oh, it's fun." And then she just texted me like on the way over here, "Don't say anything stupid." And then she goes, "And proszę nie przeklinać." And then I was like, okay.